Hello students, good morning to all. Today we will be discussing on the topic from recent advances 25, that is prostate intraductal carcinoma. Before going to the topic proper, let's have a review about the normal prostate histology. As you can see in the diagram, and we all know that prostate comprises of tubuloacinar glands. What is tubulo? That is tube-like. If you have a cut section of the PVC pipe, how do you see that is a tube? So that is tubulo and acinar. Acinar means sac-like cavities, like you see in grapes, which we have seen in example of lungs. So that is a tubuloacinar glands, as you can see, within a fibromuscular stroma. And in that you can see there is glandular, acinar and ducts which have corporoamylaceae, that is a pink homogeneous eosinophilic material within the glands. So this is how a normal prostate gland looks like. Now we can go to our topic. So coming to prostate intraductal carcinoma. So briefly telling about that, intraductal carcinoma of the prostate. It's an aggressive tumor which shows atypical epithelial proliferation within the native prostatic ducts and acini. That is the prostatic ducts and acini. It will be the same as in benign glands, but then you will see it enlarged and there will be epithelial atypia and proliferation within it. And this epithelial proliferation will show complex architecture which will be either solid or cribriform. And there may or may not be significant nuclear atypia. And coming to the etiology, usually IDC prostate is associated with defects in DNA repair gene like BRCA2, ERG gene fusion, and PTEN loss. And it is associated with poor prognosis, that is, in patients, if we see radical prostatectomy or prostatic biopsy with intraductal carcinoma prostate, they are usually resistant to the conventional therapies. And almost always it is seen associated with invasive prostate carcinoma. Now, coming to the origin. Now, this topic is a little bit of debate, but then still, some researchers say that it is an intraductal extension of advanced stage of prostate carcinoma. But in some other cases, it is said to be in situ lesion, that is, a precursor lesion just before the proper prostate carcinoma. Either way, the evidence is suggested by the thing that they say share genetic alteration with adjacent prostate carcinoma. That is, I also already said that the prostate carcinoma intraductal is always seen associated with a ductal prostatic carcinoma. So in such cases, when research was done, it was found that the genetic alteration, that is mutations, which were present in prostate carcinoma part were always seen in the intraductal carcinoma prostate part as well. Among that, 75% of the cases you had TMPRSS2 ERG gene fusion. Now coming to the diagnostic criteria according to WHO. So you should have large prostatic acini and ducts that are expanded. That means they are enlarged compared to the benign prostatic acini and ducts. And those ducts and acini should contain malignant epithelial cells. And they should have preservation of basal cells. That is, basal cell markers should be positive. The basal cells will be preserved. Unlike in prostate carcinoma proper, there will be no basal cells, but in intraductal carcinoma prostate there will be preservation of basal cells. And then this is also an important part, that is the architecture which the malignant epithelial cells show should be either solid or dense cribriform pattern or loose cribriform or micropapillary architecture. So if it is solid or dense cribriform pattern, the punched out lumina, why do we say it is cribriform? Cribriform means it has punched out small luminas in it, like a cookie cut appearance as we have described in breast carcinoma, etc. So cribriform pattern in that the luminal space should be comprising only less than 50% of the total cell mass. So in the solid dense cribriform pattern, the lumina will be less than 50% of the total cell mass. Or else the pattern should be loose cribriform or micropapillary, then there should be comedonecrosis or bizarre pleomorphic nuclear atypia. Just only if the pattern is loose cribriform or micropapillary, we can't put it into IDC-P. It should have either comedonecrosis or bizarre pleomorphic nuclear atypia. So these are the criteria. And corporoamylacea. It's not necessary that corporoamylacea should be present, but then if in malignant epithelial cell proliferation and prostatic carcinoma, if you see corporoamylacea, it is mostly a case of intraductal carcinoma prostate. So I will revise the diagnostic criteria once more because it's very important. The prostatic acini and ducts which are large and expanded should contain malignant epithelial cells, and there should be preservation of basal cells, and the architecture should be either solid or dense cribriform pattern with less than 50% of punched out luminal space, or else if it is loose cribriform or micropapillary architecture, it must contain comedonecrosis or bizarre pleomorphic nuclear atypia. So now let's come to some pictures. So this is a picture which I have taken from the paper which I have mentioned above. So in this we can see a loose cribriform architecture. A loose cribriform architecture. So what is cribriform? That is a small punched out lumina in the malignant epithelial cells without stromal invasion. Means you have a total cell mass of malignant cells. In that you will have punched out like small luminal spaces. So that is called cribriform. Now coming to loose cribriform architecture, I don't know how to explain it perfectly, but then I feel it a bit like a leafy architecture, like you see in phylloids, or else it seems like in the space you pour a lot of water, then how it disperses, like kind of. Anyway, in the first picture you can get how a loose cribriform looks like. So how to distinguish any prostate intraductal carcinoma from proper prostate carcinoma is that you put the basal cell markers. So you can see in the IHC there is a pink rim which is the basal cell marker which is positive, that is P63. And then in the second part you can see IDC pattern which is solid type, in which you can see comedonecrosis, and in that also the basal cell markers are positive. Now coming to other picture, in this you can see the acini ducts have an irregular branching pattern in the left side picture, and then there is also necrosis in that. And then to prove that it is intraductal pattern, you can see the basal cell markers are positive. So as you can see in this picture, you can see a micropapillary pattern. So why is it called micropapillary? Because in the proper papillary pattern, you will see finger-like projections with fibrovascular core. Here you are not seeing a fibrovascular core, so it is a micropapillary pattern, and you can see necrosis in the glands which are enlarged, as well as you can see corporoamylacea in it. And in the right side picture you can see HMW, high molecular weight cytokeratin, which is a basal cell marker of the prostate gland. So in this picture you can see a dense cribriform pattern dense cribriform to solid architecture in the A picture, which has a comedonecrosis in that, and to prove it is IDC-P in the right side, it has a basal cell marker given to it, which you can see it is highlighted nicely. And in the C picture, you can see it is a prostate carcinoma, which is ductal. And to prove that is not IDC-P, there is in the D picture, which is basal cell marker, which is showing it is negative. So that is how you distinguish it from ductal carcinoma. So now coming to the immunohistochemistry of intraductal carcinoma prostate, how is it important? So it is important to confirm the presence of basal cells, which I have already said, for which we use P63 and HMWCK. And then the neoplastic cells, as in prostate carcinoma, they express AMACR, and if there is mutation, they will express even ERG when there is ERG gene fusion, etc. And as I said, if there is P10 loss, there will be reduced P10 expression. Now, to rule out intraductal spread of other carcinomas, like in prostate carcinoma, there will be NKX 3.1 positive and PSA positive. So to confirm it is prostate origin, we can use these markers. And if it is a urothelial carcinoma metastasis or extension, you will have GATA3 positive. P63 and HMWCK also we can see if it is present in malignant epithelial cells, it is then indicating urothelial, because in prostate carcinoma it is only a basal cell marker and it is not present in towards the inside. If it is present in the epithelial cell bulk as well inside the proliferation, then you have to take the DD of basal cell hyperplasia as well in the prostate. So GATA3 anyway, if it will be positive only if it is urothelial carcinoma. Then if it is a colorectal carcinoma extension, if you are suspecting, you can do CDX2 or to rule out colorectal. Now coming to atypical intraductal proliferation. So atypical intraductal proliferation, when do we call AIP? That is when there are features of IDC-P but it lacks diagnostic features completely according to the WHO criteria. But it exceeds the criteria of high-grade prostate intraepithelial neoplasia also. So AIP is a lesion which comes in between HGPIN, high-grade prostate intraepithelial neoplasia, and between IDC-P. So what are its features? So we have said that loose cribriform pattern, if we see in IDC-P, it should either have necrosis or it should have nuclear atypia. So there are lesions if there is loose cribriform proliferation but there is no intraluminal necrosis as well as nuclear atypia, you are going to call the lesion as atypical intraductal proliferation. So as I said, how the chronology goes is like first it will be high-grade prostate intraepithelial neoplasia, then AIP, and then intraductal carcinoma prostate. So if we get AIP in biopsy, you must surely rule out prostate carcinoma by doing prostate MRI and serum markers, and you have to advise to immediately repeat biopsy to rule out unsampled invasive carcinomas if it is present. Now, in picture you can see here it is a loose cribriformed micropapillary pattern as you can see, and there is no marked nuclear atypia and there is no intraluminal necrosis. Now coming to intraductal carcinoma prostate versus high-grade PIN, how we will differentiate it. So in the extent of involvement, usually IDC-P involves so many glands and HG PIN involves only very few glands. Architectural pattern wise, it has dense cribriform to solid pattern, which I said, and HG pin will usually show only micropapillary to loose cribriform pattern. And the glands, it will be irregular and branching in IDC-P, versus in HG pin it will be rounded smooth contour like in benign glands. Size of the glands will be enlarged, but it will be almost similar in HG pin. Nucleus will be pleomorphic and bizarre in intraductal carcinoma prostate, as in high grade pin it will be 2 to 3 times than the benign nuclei. Mitosis will be increased in intraductal carcinoma. Glomerulonecrosis and basal cells will be present in intraductal carcinoma prostate, but in HG pin, basal cells are present but they are discontinuous. In molecular alteration, ERG expression is found and PTEN loss is found in majority of the cases of IDC-P, but in HG-P, these mutations are seen very rarely. So how do you identify it as HG-P? They have a tufted micropapillary architecture. There will be nuclear stratification, but not marked nuclear atypia. And you can see the glands are round and little enlarged but not branching, and there is prominent nucleoli. And here you can see in the IHC the basal cells are present but they are discontinuous. But they show this is sorry that the labeling is different, but it is a marker positivity in the epithelial cells, which shows it is atypical in the HG pin lesion. So what are the DDs of intraductal carcinoma prostate? Cribriform prostate carcinoma is a major DD, so that will come under the Gleason pattern 4 to 5, and it lacks basal cell lining. And ductal carcinoma prostate, they are invasive. They cross the boundaries of the glands and they invade into the stroma, and they also lack basal cells. So how to differentiate from prostate carcinoma proper is by the absence of basal cells. Now in the intraductal spread, if we are suspecting, that is why I put it under DDs, is that if you are having a prostate carcinoma adjacent and then you are seeing an intraductal spread, so you can't call it properly IDC-P also. So you can give a diagnosis of intraductal carcinoma prostate with ductal morphology in that area where there is adjacent prostate carcinoma proper. And then cribriform clear cell hyperplasia. In this you will see benign glands, but then there will be hyperplastic epithelial proliferation as well as the cytoplasm will be clear. And basal cell hyperplasia, as I said, the basal cell will be proliferated in the prostate gland, so they will show basal cell markers positive throughout the gland. And then if IDC-P is coming with concomitant low Gleason grade, that is Gleason 6 in prostate biopsy, we should report it separately. Now coming to the prognosis. As I said already, it has a poor prognosis. So if we see IDC-P, which is associated with the prostate carcinoma proper in the radical prostatectomy or biopsy specimen, you should know that the patient, there is high chance of recurrence and shorter survival. There will be metastatic failure after radiation therapy. That means even after radiation therapy, there will be metastasis to the patient. Mostly, because it has a poor prognosis and treatment resistance. It will be mostly associated with larger tumor volume, higher grade and extra prostatic extension into seminal vesicles and then to pelvic lymph nodes. So coming to the reporting of IDC-P. If there is no concomitant prostate carcinoma, we are going to report the lesion as presence of intraductal carcinoma prostate, and you're not going to grade it according to Gleason's grading. But you have to comment on its prognostic significance and its therapy implications. And if there is lesion which is only grade group 1, that is Gleason grading 6, that is the lowest Gleason's grade, then you should not include IDC-P lesion in the final Gleason score, but you have to confirm there is no presence of other prostate carcinoma by the basal cell IHC marking. And then you have to report the presence of IDC-P separately and comment on its prognostic significance, but not include it in the Gleason's grading. And if there is already concomitant prostate carcinoma which has Gleason grade score more than or equal to 7, that is grading total grade group will be more than or equal to 2, then you can include the IDC-P lesion into the final Gleason score as well as in the overall tumor extent. But then you shall still comment on the presence of IDC-P as its prognostic significance is very different. So coming to the summary of today's lecture, that is, intraductal carcinoma prostate, it is distinct entity of prostatic neoplasia. Some people debate it is an in situ lesion, but others think that is just an intraductal extension. Either way, it is atypical epithelial proliferation within enlarged prostatic ducts and acini, which will show complex architecture which is either solid or cribriform, which has less than 50% luminal space, or micropapillary or loose cribriform pattern with chromadonecrosis or significant nuclear atypia. And it is associated with increased genomic instability and defects in DNA repair genes like BRCA2, ERG gene fusion, and PTEN loss. And it is associated with poor prognosis with resistance to conventional therapies. And almost always it is seen associated with concomitant invasive prostatic carcinoma. And when it is associated with prostatic carcinoma Gleason grade score more than 7, you should incorporate IDC-P in the final score as well as in the overall tumor extent. But if it is not associated with invasive carcinoma, or it's only associated with Gleason score 6 prostate carcinoma, you just report its presence and comment on its prognostic significance. And lastly, about the atypical intraductal proliferation, if you see, then you have to advise for immediate repeat biopsy to rule out unsampled invasive carcinoma. So, students, thank you for listening. Kindly like, share, and subscribe for more videos.